Can everybody hear me in the back? Nobody's ever said I was quiet or slow. So, welcome, ladies and gentlemen. I actually have not set up a didactic for this morning. There's lots to hear. There'll be lots of people up here. It's very early in the morning, and I decided a long time ago, I have plenty of slides and we can talk about all the GI manifestations related to scleroderma, but my goal is kind of the butts and guts guy at Northwestern is not to proverbially scare the poop out of all of you. So again, for those of you who've seen me, and I see a lot of familiar faces in the crowd, we know that scleroderma affects smooth muscle. So that's everything from your esophagus to your anal sphincters and every single GI organ in between. So I thought I can come up here and talk about all of these and kind of either bore you, scare you, or put you to sleep. Or I could open this up to more of a patient forum. That's what we're here for. I don't need to hear my own voice. I hear it a lot. I don't really love the sound, especially on recording. So what I thought I would do is maybe open up the floor to all of you. If you have this, if you have questions, I'd rather start there. We always hold the questions till the end. And then 3 people get their questions answered, and the other 20 people are like, I really wish I'd gotten that in there. So I want to invert that pyramid. We're doing that a lot. I want to open this up as a question and answer forum for all of you, and I have kind of slides and info to back that up. So if you want to start with questions, that's where I'd like to go. If you don't, I'll read a bunch of slides too, and I'm happy to do that as well. So let's turn this around a little bit. Let me start with a Q&A, and I see one woman, thank you for getting us started. So please, fire away. Of course, you said ranitidine. Yes, okay, so that's a great place to start. So how many of you are familiar with the information that came out just a couple of weeks ago about ranitidine? Not a lot. Anybody taking the medication? So I don't mind today because I want people to know what we're talking about. So I'll switch between kind of the generic names and the trade names. So ranitidine is Zantac. And I'll tell you, I was taking Zantac. A couple of weeks ago, information came out that the compounding pharmacies where we get all of our chemicals to make this drug from from China, they found a chemical called NMDA in the product, and that's a carcinogen. So I had patients that started my-charting me or calling me and said, why did you put me on this medication if it can cause cancer? And I gave them the same answer I gave myself, which was I didn't know this. So I took my ranitidine and threw it in the garbage as well. So for anybody taking ranitidine or Zantac, yes, it contains some chemicals that are carcinogens, and I am recommending that all of my patients stop that. Now, what can you do in its place? Because we have a lot of people who take histamine receptor blockers before bed. It's an adjunct to the proton pump inhibitors that we take, like Prilosec, Prevacid, Nexium, Dexilant, those sorts of things. I'm recommending everybody switch to famotidine. So famotidines trade name is Pepcid. I don't recommend that you buy the Pepcid, it just costs more, but it's a 20 milligram tablet, and replace the ranitidine with that. They're pretty much bioequivalent. So that's what I've done. I went back to Target, threw out my ranitidine, and got famotidine. So that's the one I'm recommending my patients take, either with scleroderma or without it at this point. Sure, it's FAMOTIDINE. And again, I'm going to try and flip the slides that can be associated with these sorts of things. So let me get through there, because we're talking a little bit about reflux disease. And for people having other troubles, I think this is a good place to start as well. So if you have to get away from the medications, here's some of the non-pharmaceutical things that we recommend for this disorder too. Elevating the head of your bed. Historically, we talked about putting about 5 or 6 pillows behind your head. That will not work. So we're actually talking about adjustable beds, or even putting cinder blocks at the top of your bed to elevate this way, because we know that when people get reflux with scleroderma, it's due to a couple of different little things. You lose the little muscle that protects the esophagus from stomach acid. It kind of goes away over time, so you don't have that blocking barrier there. It becomes an open conduit between your stomach and your esophagus. But the other way that we get acid out of our esophagus is clearing it to gravity or pushing the acid out. And one of the issues that we have with scleroderma is that the motility of the esophagus doesn't work as well. So the acid actually pools at the bottom of the esophagus. We did a really nice study that we published a few years ago looking at acid reflux, because we say the average person who's on an acid blocker twice a day and still has reflux symptoms probably doesn't have acid reflux. They have about a 2 to 3% chance of acid reflux. It's non-acid reflux. It's what we call esophageal hypersensitivity, where normal amounts of acid cause discomfort. What we're able to show is that in our patient population at Northwestern, if you have scleroderma, you're on twice a day acid blockers, and you're still having acid reflux symptoms, the chances it's due to acid is still about 75%. Because we see that the acid pools at the bottom of the esophagus and doesn't go anywhere. Because we lose that ability to push that acid out of that area. So elevating the head of your bed, not eating 2 to 4 hours before you go to bed. I shouldn't say go to bed, laying flat. We always think about when you go to bed. What I've actually started asking my patients is, what's the interval between the time you eat at night and the time you lay down on the couch? And it's surprising, sometimes it's 5 to 10 minutes. Laying down is the issue, not going to sleep is the problem. So we want to do that as well. And we're starting to modify some of these medications. So yes, if you're taking the ranitidine, my personal recommendation is to get rid of it and try one of the alternative substances that's out there. We usually say 6 inches or so, or above it if you can. What I really like to recommend at that point. And there are wedges. The wedges work better than the regular pillows. And my colleague John Pandolfino has been doing some research on wedges as well with some good initial data, showing that can help improve symptoms too. Other questions? If not, I'll backtrack, talk a little bit about these illnesses. Anything out there you want to know? Well, maybe if we talk a little bit about these, that'll spur in some questions. So, take-home points. I think as many of you know, scleroderma affects multiple organs in the body. That's why there's going to be multiple experts and speakers here today. But the GI tract is the second most commonly affected. Okay, it's the skin first, the GI tract second. You can see 2/3 to almost everybody gets some sort of GI involvement. And this can be in multiple different forms. A lot of the people that I see in my clinical practice, they walk in the door and I evaluate their symptoms from top to bottom. And then I never actually see progression. It's actually few and far between that I see people get a rapid progression of these symptoms. And we know these symptoms can come on at any age. The other thing we know too is we can't put our blinders on. We can't look at this in terms of it being a vacuum that all GI symptoms are related to scleroderma. Sometimes people just get illnesses. I mean, think about it. The acid blocker industry is a multi-billion-dollar industry, and it doesn't isolate just the scleroderma. So there are people walking around on the street that have the exact same symptoms. We have to be able to differentiate between these. And we know what really happens is that we lose the vascular input to the nerves. If you lose the nerves into the smooth muscles, the muscles don't move as quickly or as efficiently as they should. So you lose contraction or you lose propulsion. Now there's a really nice handout back there from my colleague, Dr. Kano, who's a professor over at the University of Michigan. But I was reading through it very quickly to make sure that I agreed with everything that was said. And one of the things that's said in there is that it's a progression over time from top to bottom. I don't agree. You can actually have multiple different systems involved, but you can skip all over the GI tract as well. And in the GI tract, it causes multiple different types of disorders. Reflux. Reflux comes in multiple different forms. For some people, it's classic reflux. It's that, I feel that burning coming up my throat and into my mouth. Or it's just this substernal chest pain. People who come in and they come in with non-cardiac chest pain, 90% of average healthy individuals, it's due to reflux. So if you feel that burning sensation back there, but it doesn't make it all the way up, that can be it too. Regurgitation of acid or food. So these are all very, very common symptoms that we see across what we call the classic reflux spectrum. But there's also the supralaryngeal reflux, the burning tongue, the hoarse voice, the chronic cough, the sinus infections, and then the pulmonary disease, where the acid gets up from the esophagus and into the lungs and causes some of the inflammation and scarring. That's something we work very closely with our pulmonary colleagues about, because there's a significant percentage of the population that has what we would call silent reflux. You don't even know it's coming up, but it's having major deleterious impacts in the back of the throat, the teeth, and the lungs. So we worry about that one as well. Gastroparesis, just as the name implies. Paresis is delayed gastro is stomach. Your stomach doesn't work as quickly as it should. And some people get GAVE, or what we like to call watermelon stomach, and I'll show you some pictures of those. That really doesn't lead much to anything other than iron deficiency anemia. But iron deficiency anemia leads to fatigue, decreased exercise tolerance, and in some people, pica symptoms. So if you ever just have cravings to chew ice, eat dirt, maybe chew on your windowsills because you like paint, that can actually be related to iron deficiency anemia. So we ask about that and people laugh, but it's related to low iron. It's your body saying, I'm starving for iron, where else can I try to get these other things? SIBO, small intestinal bacterial overgrowth, or CIPO, chronic intestinal pseudo-obstructions. These are some of the hardest things we treat. Constipation, and then what I think is the worst thing, so I treat this in my subspecialty clinics, fecal incontinence. Okay? So we all have an esophagus. At least I hope most of us still have our esophagus. And again, this is the most common GI organ involved. It can affect up to 90% of individuals. We talked a little bit about these symptoms. And I just want to get through what we're looking for in some of the testing that we do. So any of you had esophageal testing? Few? Okay. Again, in the handout, it's going to say one of the ways that we assess the esophagus is through a barium esophagram. We really don't do that anymore. You can find reflux on an upper GI series or when you swallow this barium, but the reflux component doesn't really correlate to anything. We've shown that over and over again in GI clinical practice. So a lot of times what we do is we do pH testing. And we can do this in one of two ways. We can use a Bravo pH capsule. This is where we go down your throat with a scope. We leave a little capsule. It's about yay big by about yay wide on the bottom of the esophagus, and it sits there for about 2 to 4 days and it measures acid. And you get a little clicker to take home, and every time you feel a reflux symptom, you push that little clicker. It tells us how often there's acid in the GI tract, and it tells us whether or not your symptoms correlate to acid reflux events. Because there are a lot of people that come in and they click that over and over and over again, but there's no acid reflux whatsoever. And that's important because these are treated completely differently. So this is a pH tracing that you see up here, and I don't know if my laser will work on this. It usually doesn't on TV screens and it won't here. What we're looking at is the number of times or the amount of time that the pH is below 4. Okay, and you can see that a pH that stays below 4 for an average of 5 to 6% of the testing time is consistent with acid reflux. Not hard for us to look at. One of the other tests that we do frequently at Northwestern is a test called pH impedance. This is for somebody who's already on acid blockers, usually twice a day, where you're saying, I'm still having reflux symptoms, and we're saying, okay, we know there's a high prevalence of acid reflux in scleroderma, so the question is not so much, do you have acid reflux, but again, are you breaking through? And this is important in scleroderma because, as I mentioned earlier, about 75% of the individuals that we test still have acid reflux, as opposed to non-acid reflux. Well, that's things like pepsin, bile, the chemicals that are in your stomach come up your throat, the ones that are there to break down food, they can get up into the esophagus as well. And that's important because we can't treat that with acid blockers. I can't treat an alkaline substance like bile with an acid blocker, it doesn't work. Or people that have esophageal hypersensitivity, where the acid's coming up at normal amounts, but it's causing symptoms. And then there's a fourth category that we don't see most frequently in scleroderma, which is called functional heartburn. That's where you click the button all the time and there's no acid reflux whatsoever. So we're trying to differentiate that. With the pH impedance catheter, we thread a very small catheter, usually while you're asleep, through your nose. It goes down into your esophagus and stomach. We leave it there for about 24 hours, and we can not only measure with that one what's coming up your esophagus, is it acidic, is it non-acidic, but we can differentiate solids and liquids and gases. So it tells us a little bit about what's coming up as well. And again, if you look here, as I've marked out, that's the entire period of time where there's abnormal acid exposure. So very easy for us to look at. We talked a little bit about treatments here. There's things that you see at the bottom with diet modification. We've been able to show at Northwestern that weight loss is key. So not so much for thin people, but for people that are overweight or morbidly obese, reducing weight has a significant impact on reflux. Tobacco, alcohol, those weaken that little muscle at the bottom of the esophagus, the lower esophageal sphincter. Allows to open more frequently than it should, which allows more acid into the esophagus. So simple things that we can do. When we talk about pharmacologic treatments, you've got the standard over-the-counter things like Maalox, Pepto-Bismol. In the setting of scleroderma, I'll be honest, these do not work very well. We have the histamine receptor blockers. We talked a little bit about Zantac, and you can switch to Pepsid. I do not like the other one that's on the market, which is Tagamet, because it has a lot of side effects related to it and drug-drug interactions. So Pepsid is the one I really like to go with. Yes? Good question. It's the last group, okay? It's the proton pump inhibitors. This is the strongest class of medications, and these are the medications that we most frequently need to use to treat scleroderma-based symptoms, because we really have to get that pH into that, we shouldn't say normal range, but higher range, because again, we've lost in a lot of people the ability to clear that acid out of the esophagus. So this would be your omeprazoles, your Prilosec, your lansoprazoles, your Previcids, your esomeprazole Nexiums, your dexlansoprazoles, their Dexalans. And we try to find the right amount for the person that we're treating. Now, I'm sure that a lot of you have heard about some of the side effects related to these medications. A lot of these come from retrospective studies, which means they're correlative, not causative. For example, you may have seen in the last couple of years that proton pump inhibitors cause dementia. My mom's on top of all of this. Sometimes my parents figure these things out before I even do. So I remember I got a text from her one day when I was in clinic, because my dad has Barrett's esophagus. We'll talk about that a little bit. And she said to me, and she was all in a flurry, she said, Darren, your dad's been taking Prevacid for years for his reflux and Barrett's esophagus, and now it causes dementia. Is he gonna go crazy? Especially in people over 75. And I laughed, and my mom and I have a cynical relationship. Strike that from the tape. And I said to her, and I texted back, I said, Mom, if you haven't driven Dad crazy by now, I'm pretty sure the Prevacid isn't going to do it, okay? So if you actually look at the studies come out of Germany. And what is something that was kind of designed in that Germany, Austria area? Anything you can think of? People flock to it about once a year, maybe around this time of year? Oktoberfest, yeah. They like to drink beer. And lo and behold, alcohol can induce dementia. But it's one of the confounding factors that they didn't control for. So there are lots of external processes in these. So what we say for most individuals is, we look at the acid blockers and we say, do the benefits outweigh the risks? And in most cases, the answer is yes. Because again, a lot of the things that we worry about, a lot of the things that are in the handout in the back, are correlative, they're not causative. We're doing prospective studies now to look and see if acid blockers really cause these problems. And in most cases, to this point, they have not borne fruit, okay? We're not seeing that the PPIs are causing these sorts of things. But they're scary and they're concerning. We talk a little bit about losing minerals in your body and breaking down your bones and causing kidney disease and causing dementia. And we even saw a study that showed that acid blockers were killing you. We're not buying into that one yet either, okay? So if you need them, absolutely you want to take them, because these are some of the things that we worry about. We worry about inflammation at the bottom of the esophagus. We worry about scarring the esophagus, peptic strictures, which can lead food to get stuck, and Barrett's esophagus, okay? So what I'm showing you here are some of the erosions that you can see, some of the inflammation at the bottom of the esophagus. This is what a stricture would look like. And this is what Barrett's esophagus looks like, and it's this outline here. And it's not that you need to memorize these, but you need to be aware of them, because if the esophagus isn't working in scleroderma, there's a little bit higher risk, and it's something that we have to be concerned about. So sometimes people will come to our clinics and they'll say, I don't need an acid blocker, I don't have any reflux. But you can develop these signs and symptoms without reflux, which is why sometimes we may recommend an upper endoscopy. I'll tell you, I do upper endoscopies all the time for risk stratification, because I don't want to put people on medication if they don't need it. And if I don't find anything down there, and my pulmonary colleagues aren't concerned that there's acid getting into the lungs, then I'll keep you off the acid blockers, or I'll keep you on the weaker medications like the H2RAs. Used to be the Zantacs, now the Pepsids, for a little bit of acid protection. Okay? The other thing we worry about, difficulty swallowing. Remember, when you swallow, there are three major processes. One I'm not going to talk about today. There's the oropharyngeal component. That portion, that is all skeletal muscle. That is not really impacted by scleroderma. But what can make it difficult is if you have scarring or you have thickening of the skin around your mouth. If you can't open your mouth, if you can't extend your muscles, you can't chew very well. And if you get a big bolus of food into your esophagus, it can get stuck, okay? This is how I think about the esophagus of somebody with scleroderma. It's a lead pipe. Okay, we can put a catheter through your nose. It's called an esophageal manometry catheter, and we can have you swallow thin liquids and thick liquids, and we have sensors. Every centimeter, we can watch the entire contractile process in scleroderma. And I'll show you that in a few slides. And in most cases, we get what we call aperistalsis, or no movement. So why do I think of it as a lead pipe? Because when we train our med students and our residents and our fellows, we talk about scleroderma being a disorder where it makes it difficult to swallow solids and liquids. But what I found historically in clinical practice is that most people can actually tolerate swallowing liquids. Because, remember what I said, at the bottom of this pipe that's supposed to push things down, there's that little valve. And in most patients with scleroderma, we lose that valve. So this becomes an open pipe from one end to the other, okay? And so what we see is if you swallow solid foods, most people have problems with meats, chickens, breads, because they're hard to get down, they get stuck. But if you swallow a liquid, think about it. If you got a pipe that's open at the top and a pipe that's open at the bottom, and you throw water into the pipe, it's probably going to get through the other end, right? It imbibes down the side, and it comes out. So we have more success with the liquids. This is the test that we do. It's an esophageal manometry catheter. It goes down the nose into the esophagus. And when somebody swallows, this is what it looks like. And unfortunately, again, I don't know if my arrow works here. I'm going to try it. Can you guys see the arrow up there? Okay. This is what happens. When you swallow, the upper esophageal sphincter relaxes. This little muscle called the cricopharyngeus. Okay? This is all still skeletal muscle. Then you've got a transition zone into smooth muscle. And for somebody whose esophagus works, the bolus gets pushed over time down the esophagus. This is the lower esophageal sphincter. It opens up, and the food can get into the stomach. Okay? That's what we expect to see in a normal, healthy individual. Here's what we see in scleroderma. You swallow. That skeletal muscle portion works. There's no propagation whatsoever. And there's really no tone on the lower esophageal sphincter. So again, in somebody like this, in most cases, I expect that the liquids will get through. We push it through the upper esophagus and they just kind of drain through. And because there's no pressure down here, like we see at baseline in a healthy individual, those liquids will usually get through that process. Okay? And it's a nice test because a lot of times we're not sure if somebody has scleroderma, and we really don't see this sort of pattern in most other esophageal diseases. So it's almost pathognomonic. A lot of times patients get referred to my clinic and they say, can you do the esophageal manometry to look for scleroderma esophagus? And sometimes we can help make the diagnosis from that. Now when it comes to treating dysphagia, we're not good. There are people around the country who legitimately are trying to work on these different pressure transducers. I like to call them the jump start for the battery of the esophagus, but we're just not there yet. So what do? We avoid foods that cause discomfort. We have you chew vigorously. We really want you to mash that food up. You want to follow the solids with liquids. Give yourself that bolus to push things through. And then again, a lot of people get liquid supplements to treat this disorder. When everything fails and you can't get anything down, that's when we start talking about feeding tubes. But I don't want to scare anybody. They are more the exception than the rule. Okay, I do not place a lot of feeding tubes in the setting of scleroderma, thankfully. So we got our stomach. Most common thing that we see in stomach, again, yes, please. Anything that causes your symptoms. So most of the time people can walk into my office and say, here is a list of foods that stick, and then I have to say, just avoid them. Yep, that's it. Great question. Thank you. Please. Acid reflux burn your stomach? No. So that's where we differentiate. Historically, there have been two separate disorders that have been considered one and the same. When we ask about the sensations in the stomach, right below your breastbone, it's a disorder called dyspepsia. And dyspepsia covers a gamut of symptoms that include burning sensations in the stomach, nausea, vomiting, bloating, distension, feeling full very quickly after meals. You'll see that these symptoms overlap with gastroparesis, which is why we try to differentiate the two. But the reason it's very easy to consider these one and the same is because the predominant treatment for dyspepsia is acid blockers. So we give the exact same medication, so people overlap the disorders and consider them, the exact same type of thing. But no, acid reflux is definitively going to be acid getting into your food pipe, into the esophagus, whereas the burning and the dyspepsia stays right here in that stomach region. Can scleroderma cause ulcers? You can have ulcers in scleroderma. The disorder itself should not cause the ulcers. Yeah, great question. We don't see a lot of ulcers in the scleroderma populations because people are on preventative acid blockers, which is the treatment for more of the esophageal symptoms. Question? Oh, can I repeat the question? Yeah, sorry. The question on that one was, does scleroderma cause ulcers? I said, no, the disorder itself doesn't cause ulcers, and most people are already on acid blockers, which is the best treatment and primary prophylaxis against an ulcer, so I don't see those that often. So the question is, would you come to see somebody like me if you had an ulcer? Yeah, we do the peptic ulcer disease too. One of the most common causes of ulcers, aspirin, non-steroidal medications, H. pylori bacteria, steroids if you're on them. Steroids alone don't cause ulcers, but steroids plus aspirin or other NSAIDs significantly increases the risk of developing an ulcer. So it's kind of a symbiotic relationship. And I know a lot of you take steroids or see steroids in some portion of this process. Ibuprofen, yes. Yep. Any NSAID. So ibuprofen, Aleve, Advil, naproxen, Nuprin, any of those, along with steroids, can increase the risk of an ulcer. But again, the vast majority of individuals are already getting primary prophylaxis against the ulcers. in the sense that you're using the acid blockers. And in this setting, the key is to be on a proton pump inhibitor. We want you on those PPIs as opposed to those H2RAs that I showed in the slides. Great question. Do I recommend a probiotic? The answer is definitively no. Probiotics are the rage in this day and age, but there is little data to support their efficacy. Years ago, I wrote a systematic review on probiotics for irritable bowel syndrome. I've since kind of tiptoed away from that. We need more data, and that was kind of one of my points. In the handout that's back there, it talks about probiotics, especially for somebody with small intestinal bacterial overgrowth, and I'll come back to that. You do not want to add bacteria to your small bowel. Your small bowel, yes, it has concentrations of bacteria, and they increase as you move closer to the colon. But there's no such thing as really adding a healthy bacteria to the small intestine, and we have no data whatsoever that shows that giving probiotics in the setting of scleroderma has a benefit. So I'm really, really not doing that anymore. Please. Yogurt. Yeah, great question about yogurt. If you're taking antibiotics and you have a history of antibiotic-associated diarrhea, there is some data that taking a probiotic while you're taking the antibiotic may reduce the risk of that antibiotic-associated diarrhea. Yogurts themselves, I think they're very healthy. If they contain probiotics, wonderful. There are some yogurts that have pro-motility properties to them. At least clinical trials have shown that. So the trials have shown that they can move things through the GI tract, but they have not actually shown that they reduce symptoms related to reductions in motility in the GI tract. So my anti-yogurt, no. Eat whatever you like, whatever you can, whenever you enjoy it. Do I think that it's going to give you some sort of health benefit? The jury's still out. I don't like to say that probiotics are not beneficial or that they can't do something. I guess the better way to say it is they're invalidated. The studies that have been done using probiotics across the board for most GI illnesses are so methodologically flawed that we can't make heads or tails of the results. There are some negative studies. We don't have a lot of positive studies. It'd be something to look into for sure. But I don't want all of you going out and thinking, I need to go get the latest and greatest probiotic. We just don't have the information we need. Sorry? Okay. Other questions? No, my theory on probiotics is this. I can't tell you if they work or they don't work. And yes, there is a placebo rate to probiotics. In the irritable bowel world, there's about a 30 to 40% placebo rate to probiotics. So think about that. 1 out of every 2.5 to 3 people that I treat with a probiotic is going to feel better, even if it's doing absolutely nothing. People come up to us at meetings all the time and say, do you think it's a placebo effect? And I say, it could be, but I don't care, because for the average individual, they're pretty safe. Now, that being said, when we write our cards on probiotics, there is some danger in people taking immunosuppressives. So that's where I kind of tiptoe or draw the line. If you're on an immunosuppressive and you don't have a real reason to take the probiotic, I certainly don't think there's enough data out there to recommend that you should use it. If you want to use a probiotic and you don't have those concerns, here's what I tell everybody. Take one at a time. Get them from a reputable company, so I do agree with the probiotics that are recommended in that handout, and take it for a month. If you don't have a benefit in a month, don't waste your money. Save your money, go on a nice warm cruise to Cancun when it's cold here, okay? Don't waste your money on the probiotics. 1 month, if it doesn't work, move on. Okay. So a little bit about this disorder. Gastroparesis, and I'm going to kind of move through quickly because I know I'm on a time limit here. Delayed stomach emptying occurs very quickly. We're talking about dyspepsia. This is one of the big issues we have in the GI motility world. Dyspepsia versus gastroparesis. They present with exactly the same symptoms. Abdominal discomfort, sometimes after eating, nausea and or vomiting, feeling full very quickly after meals. People can develop overlapping sitophobia, which is a fear of eating, which can cause weight loss, bloating, and distension. How do you work this up? EGDs and gastric emptying studies. Here's what the stomach looks like. I picked a pretty picture, if I may, of what it looks like when there's some food left in the stomach. I've got ones where you can play name that food. Big bezoars, big concretions of food that go from the body all the way to the end of the stomach. The best test, however, the one that we use to define gastroparesis, is this gastric emptying study. You eat some eggs and toast or some oatmeal. It's labeled with technetium. We can pick that up with a special scan, and we measure your stomach emptying at 1 hour, 2 hours, 3 hours, and 4 hours. Again, in the handout it says most people will empty their stomach 50% by 90 minutes. That is not true. The American Neurogastromotility Society and the American College of Radiologists break this down in a completely different way. So if you're going to get a gastric emptying study, you're not at Northwestern, you're not in a major academic institution, I beg all of you to ask the person referring you or the radiologist doing it How long is this test going to be? And if they say 1 hour, 90 minutes, or 2 hours, say no and come to one of the academic institutions, because those tests are read incorrectly. And the thing I hate to do most is to repeat tests on my patients. I don't like doing that, but they're read incorrectly. I can explain that to you if you want to know about it afterwards. There's not enough time for me to go over that. But case in point, we need a 4-hour validated gastric emptying study. 50% emptying at 90 minutes does not give me an answer one way or another. How do you treat this? Looks a little bit like reflux, right? Small, frequent meals. We say graze throughout the day. We say low fat, low fiber. We now know that there are big differences between soluble fibers and insoluble fibers. We don't know that a low fiber diet is the best way to go anymore. And this is something that myself and Beth Dorfler, my dietitian, are going to start looking at in the next couple of months. We actually think that fiber may not be as detrimental as we think. And we'd like to add back some of the foods so that you can enjoy some of the things that we've had to take out. But also it reduces the likelihood that we're going to have to use things like feeding tubes and other supplements and medications if we can modify the diet that way. If there's nausea and vomiting, we have lots of antiemetics we can use. The prokinetic medications out there are not a panacea. Metoclopramide, extrapyramidal symptoms. So people can get numbness and tingling, involuntary eye blinking, lip smacking, tongue thrusting. We don't love that drug. Domperidone we can get from Canada. I put people on that one first. It's not approved in the United States. Erythromycin is a horrible drug. Not because of what it does. You're all like, why would an antibiotic be horrible? I like to call it the piglet chasing the Oreo. Any of you ever been to the Wisconsin State Fair? Every hour they let 4 piglets run around a track for an Oreo. One gets the Oreo and they love the Oreo, I'm sure. What erythromycin can do is it can give you your life back. It can completely take all those gastroparetic symptoms and get rid of them. For about 4 weeks, every single person who goes on this drug develops what we call tachyphylaxis, which means the result that you get goes away very, very quickly. So people come in, they're like, Dr. Brenner, you're amazing. I can eat again. I went over to Gino's East. I had a deep dish with sausage. And then 4 weeks later, it's all gone. Okay, I call it cruel and unusual punishment. I don't like to do that. But one medication to keep your eyes out for, a new medication called prucalopride or Motegrity. It was FDA approved in December of last year for chronic constipation. But we have been using it for a decade. We get it from Canada and other places. It's a serotonergic agent. It has whole gut motility properties. And my friend Jan Tak in Belgium just published a study in the American Journal of Gastroenterology showing that it can be beneficial for symptoms of gastroparesis. Nausea, vomiting, fullness, quality of life all improved. The problem is there's not an insurance company yet that's going to cover it for gastroparesis. When I fought for it, they say they need at least 2 clinical trials before they're going to approve it. So hopefully you have constipation, or maybe you have a doctor who thinks you have constipation and prescribe it for that. Okay? So if you have overlapping constipation and gastroparesis, this right now is my go-to. Yes, ma'am. Motegrity? Sure. So it's a new drug. It was approved last year, but it's FDA approved in the United States for chronic constipation. The issue with it is that it's a serotonergic agent. It looks a little bit like a medication called cisapride that we used to use years ago, but cisapride was taken off the market because it was causing cardiovascular complications. This one is not the same medication. There have been numerous clinical trials that show that it's cardio safe. There's another one taken off the market that was called Tegaserod or Zelnorm that was actually reapproved in the US in April of this year. April, September, one of the two, forgive me. The problem with that one is it's more restricted, it's more limited. You have to be an individual who's a woman under the age of 65. You can have no cardiovascular events, so no history of heart attacks, strokes, TIAs. You have to have 1 or less risk factors for a cardiovascular event, so that's hypertension, hyperlipidemia, those sorts of things. Your kidneys have to work pretty well, your liver has to work pretty well, you have to have no history of abdominal lesions, and there are a lot of other contraindications, so it's a little bit more difficult to use. That's the other one that's out there. So my first line agent in this situation would be the new one, the prucalopride or the Motegrity. GI bleeding, again, I have to run through these quickly. This is what we see sometimes. If you're diagnosed with iron deficiency anemia, your doctor, your rheumatologist, your primary care physician may refer you to GI because our concern in this situation is something called GAVE, gastric antral vascular ectasia or watermelon stomach. These are these little blood vessels that form at the back of the end of the stomach. They can break and bleed, and they bleed so slowly you never know they're there. They are very easy to treat. This is my favorite thing to do in the whole wide world. I put a little laser beam through my scope and I zap these blood vessels, and you can see here that's what happens. We burn these blood vessels right off the lining of your stomach. Now the nice thing is you don't have any pain receptors along this surface of your stomach. It doesn't hurt at all. You come in, I can zap these 100 times, you go out and get an M-burger across the street and feel absolutely fine. And we can get rid of these usually with a couple of sessions. And that's what it looks like after the first treatment. So again, before, after. And that will take care of the iron deficiency anemia. Again, another picture of us zapping this. Okay? So thermal therapy is the best thing we can do, and sometimes we'll supplement your iron. In terms of the small intestine, the things we worry about, small intestinal bacterial overgrowth, if the small intestine doesn't work, the bacteria can sit there and they can grow and grow and grow. This can lead to a whole bunch of different things. You can see here on the slide, the most common one that we get is gas, bloating, and distension. The ones we worry about are diarrhea and malabsorption. There are lots of antibiotics to treat this. I have my own treatment combinations du jour. Suffice to say, the one I like the best at the top of this is rifaximin. It's a non-systemically absorbed antibiotic, and I've been using this for 10 years. I titrate that to the lowest dose that an individual needs to take, and I feel very comfortable with its safety profile because it doesn't leave the GI tract. And our patients with cirrhosis or end-stage liver disease, they develop complications where we give this medication to them twice a day, every day, for their entire lives. We don't see major complications. There are other antibiotics, but I'm concerned about cycling those. And again, you can ask me questions later. This is the other issue we worry about. This is the hard one to treat that can lead to malnutrition and a lot of times needing some sort of external feeding apparatus. This is SIBO, or chronic intestinal pseudo-obstruction. This is where your small bowel distends. It does not contract very well. It does not absorb very well. And this is where you do the vast majority of your digestion and absorption. And there are ways to treat this as well. One of the ways we treat this is with a medication called Octreotide. This is a medication that can stimulate small bowel motility. And this is just showing you some patients. This was a nice study that came out of Michigan years ago. And talk about how we've advanced the science. In 1991, you could get a paper in the New England Journal of Medicine with less than 30 people enrolled. Now we just laugh at you at that type of number. But you can see the bars that aren't shaded is before the Octreotide. People with scleroderma, their pain, nausea, and bloating scales. And during Octreotide use, how much better they got. And then the number of episodes of vomiting dropped from about 3.5 to almost 0 on this medication. People are not necessarily comfortable using this medication, especially in clinical practice. So most of the time you're going to see this used as a last line agent at academic centers. For the colon, we think about constipation. There's lots of different ways to treat constipation. Again, I'm going to skip through this. There are lots of laxatives out there. A couple of things. Number one, I do not like Colace. I do not like a stool softener because the problem in scleroderma is motility. If you have stool that doesn't move and you give a stool softener, you're just going to make yourself have soft stool that doesn't move either. The other one that's in a lot of the handouts is lactulose. We have lots of therapies out there now. I am not a fan of lactulose. It's a non-absorbable sugar. And because it's not a non-absorbable sugar, it gets into your colon where the trillions of bacteria down there turn it into hydrogen, methane, and carbon dioxide. Gas, 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 gas. So if you already have gas at baseline or bloating at baseline, this is going to make you worse. There are many other laxatives out there that will not cause that side effect. The thing we worry about again is transit. This is a test we can do. This is called a radiopaque marker test. Basically what you do is you swallow a capsule with a bunch of markers in it, and 5 days later we get an x-ray, and most people with scleroderma look like this. The markers are scattered everywhere, consistent with slow transit. Some people have an evacuation disorder where you can't get the markers out. This is just treatments of constipation. And just very clearly, if you look down the list, it's kind of funny, huh? This is the experts recommending these. We make strong recommendations for every single thing on there. I don't know how useful that is for everybody. Okay. Fecal incontinence is common. I'm going to kind of glance over this one. We can talk about this afterwards if you have questions. This is the catheter that we use to define fecal incontinence. It looks like the esophageal manometry catheter. We put it a ways into the rectum. And again, what we normally see is that the resting tone, which is the internal anal sphincter, this is your number one fail-safe to not have leakage, is weak because that internal anal sphincter is a smooth muscle. Also, over time, these muscles thin and they fibrose. So as we get older, this internal anal sphincter gets scarred. Also for the ladies in the room, If you've had a baby vaginally, there's a 1 in 3 chance you tore this muscle. So the body will compensate for that tear in many cases, but the tearing plus the atrophy plus the loss of neural innervation can lead to fecal incontinence, and we've got lots of new ways to treat that too. One of them that's in the handout is the sacral nerve stimulator. This is a very small trial, 5 people, but you can see pre-post the number of weekly incontinence episodes almost went to 0 in every patient that was trialed. So I'm going to put up here as we just kind of take a few minutes of Q&A, what happens in the GI tract, what we can do to work it up, and what our primary treatments are. But the take-home point, if I can leave you with one, is this. When you come to see one of us, it's not an academic adventure. I am not going to torture you with a bunch of tests so I can smile at you and say there's nothing I can do about this, okay? For the vast majority of these illnesses, we started these lectures 10 years ago. I had a few things that I can offer. 10 years later, there are lots of things that we can do to treat the GI complications of scleroderma. So if you're having them, please come see us. Questions? Other questions? And I know some of this is not stuff you want to ask questions about in an audience, especially fecal incontinence, those sorts of things. We have a hard enough time getting people to come in and talk to us one-on-one. So I will hide in the back of the room later if you have personalized questions. Yes, ma'am. Yeah. So the question is, young woman, we know that we run a lot of tests with this disorder to keep everything on track, and there is a fear of the test. Like I said, a lot of the tests that we talk about up there, the pH impedance, the esophageal manometry, those can be done awake, and in the vast majority of individuals, we do them awake. But in Northwestern, I feel very strongly, especially if you're having issues swallowing, getting these things down can be a little bit brutal. We try to minimize as much as we can by doing a lot of these tests under sedation. And we actually have tests now that we can actually find out some of this information while you're sedated. So while you're asleep, we can replicate some of these things, although they're experimental. What I like to tell people when it comes to the GI test, in deference to my colleagues in cardiopulmonary medicine, one of whom's in the back of the room, is usually in the GI tract, it's a one and done. So I'm gonna do this once and I usually get the information I need. These are not usually repetitive. And these are longer conversations and we're very comfortable having them. We want people to feel comfortable with the information. That is step one. Well, the other thing is tell her to come in and we'll just have a conversation. Remember, at the end of the day, I don't force a tube down anybody's throat. At the end of the day, it's a personal decision on what you want and what you don't want. And if people don't want the test, sometimes we'll just empirically treat depending on what the issues are to see if we can get it better. And that's understandable. Now, is fear of what is it? Fear and anger? Yeah, I can absolutely understand that. And to kind of promote one of our other groups, in the GI tract, especially in the motility world, we don't look at this as just a biologic process. This is a biopsychosocial world. We live in our biopsychosocial bodies. And to forget that the brain plays a role in all of this, in anything in this day and age, is kind of obnoxious. So within the GI division, we have an entire center for biopsychosocial treatment. And we have 3 behavioral psychologists that do nothing from reflux to fecal incontinence, deal with the concerns, the fears, and the stigma related to these disorders. And I have specialized clinics where we work together to be able to do that. So if we need to get past that piece, I have people within that multidisciplinary program that can help with that portion too. And that's what they're there for, and that's what we want to do. Absolutely. Please, yes? Yeah, most of the tests that we do, we don't have to do again. So for example, if I do a test and I find you have acid reflux, that's what I need to know, you have acid reflux. If your esophagus doesn't work, in this day and age, it's not coming back. I'm not gonna repeat those tests. The only ones we most of the time repeat would be if we have to go back down and keep burning down those little blood vessels to get them out of the stomach. But usually for the GI test, it's a one and done. It coming up. Yes, if I could, what testing's been done? Did they have that test I talked about, the pH impedance test, placing the catheter, leaving it for 24 hours? Okay, so the nice woman in the back is saying something we hear very commonly. I have acid reflux. I'm taking twice a day acid blockers, and I'm taking something at night, and I'm elevating the head of the bed, and I still have reflux symptoms. That is a common occurrence. And there are stronger medications than pantoprazole. For all of you in the audience, it's surprising. My colleague Peter Carrillas did a study on this before. Pantoprazole is actually one of the weakest acid blockers. Compared to omeprazole, it's about 6 times weaker. So omeprazole is 6 times stronger. So sometimes we can change the acid blocker. Sometimes we do that test to see if it's still acid. And we have other medications that are dual releasers. They're longer actors that we can try to use as well. So it'd be worthwhile to look into that and see if you're still dealing with persistent acid reflux. I'm going to get pulled off the podium here in about a second. So with that, I will say thank you very much. If you have questions, I'm not going anywhere. I will hang around. Anything you'd like answered, I'm happy to do that. Thanks again.